Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy. And we appreciate you tuning in, whether you're an SLP, a teacher, an EI provider, an allied health professional, or a parent or guardian of somebody with speech and language needs. We hope this podcast will give you some valuable information and keep you at least a little bit entertained. In our podcast, we will review resources, literature, and discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA professional development. For more information, go to our website, www.slpnerdcast.com. Before we get started, the powers that be require that we read everyone's financial and non-financial disclosures. Financial disclosures, Tracy is currently employed in a private practice setting in Boston, Massachusetts. She owns her own practice and has an online learning platform called Guest Monster Games. I am the owner-founder of Grand Bois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. Amy is an employee of a public school system and co-founder of SLP Nerdcast. Non-financial disclosures, Tracy is a member of ASHA and the corresponding special interest group SIG 13 for dysphagia. Kate and Amy are both members of ASHA SIG 12. We both serve on the AAC advisory group for Massachusetts Advocates for Children. I'm a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis special interest group. So, Aim, what are we talking about today?
Well, we're very excited to have Tracy Callahan back to speak with us about feeding and swallowing in the schools.
Tracy, we're so excited that you're here again.
So excited.
Thanks for having me back, guys.
We didn't scare you away.
No, I had a lot of fun. I hope what I talked about was helpful.
Great.
I found it very helpful, especially since I still don't know anything other than what you told me last time. So I am looking forward to learning even more. So how does today's episode differ from the feeding and swallowing content that we covered in part one?
So part one, we talked more about assessment considerations and how it relates to the school, also some instrumentation. And today I wanted to take a deeper dive more into the therapy and to maybe define some of the terms that would be important to learn when designing therapy.
Awesome. So our three learning objectives for the day are three buckets. Number one, identify and define modifications and compensation strategies commonly used in feeding and swallowing therapy. There was a lot of big words in there. I'm looking forward to learning more. Bucket number two, identify and explain exposure strategies to address sensory-based feeding issues. Also going to be an interesting one. And bucket number three, define and explain food chaining techniques. I've never even heard of what that is, so I am excited to dive right in. So let's dive right in.
Okay, so one of the things that I wanted to cover before we started, that we had started to talk about a little bit in our last episode was, do we need special certification from ASHA, so the American Speech, Language, and Hearing Association, to treat feeding and swallowing?
Because there's a specialty for that, right? That's a specialty.
Correct. You can get that as a specialization. It's one that I considered getting, and as I was in the process of working on that, I had my first child, and that was very time consuming. So unfortunately, I was not able to complete that. But part of it is that you need quite a bit of contact time and continuing education to be able to achieve that. And that's a specialization that you can get through ASHA.
So as somebody who, may be a general practitioner in the school, do I need that to be able to follow through with any strategies or?
Absolutely not, no. So the ASHA Code of Ethics tells us that you need to be competent in the area that you're practicing, but you don't need to have the specialization for that. And there's no ASHA certification that you would need to get if you were to do instrumentation, for example, like the swallow studies or the fees. You don't need to get a special piece of paper from ASHA that says that you can do that, but you do need to get contact hours and training. And a lot of different sites, like a hospital, for example, will put you through their own protocol as to make sure that you've gotten the experience that you need so that you're competent in that area in both providing the treatment around it, the instrumentation itself, those types of things.
So you need to be competent. You do not
Yes.
need to be a certified specialist or, go through that specialty certification process through ASHA. And you had mentioned this in our last episode when I had asked, so you're a school-based SLP, you don't feel like this is in your area of competence, but based on IDEA and FAPE, you're required to provide X, Y, and Z. What do you do? And your first recommendation was to go back to, if you had an evaluation from a clinic-based setting, go to contact the feeding assessment team out of the clinic where the client had or the student had come from. Are there, aside from this amazing podcast, which is hopefully going to be valuable information, I know that ASHA has a lot of recommendations also. Are there any other, I guess maybe this is a nice transition into identifying and defining some of these compensation and modification strategies, or getting into what this treatment actually looks like?
So I would suggest to anybody who is not comfortable treating feeding and swallowing, that part of the way to get comfortable treating feeding and swallowing is to maybe review your notes or some of those books that you kept from grad school that you swore that you would read again. There are also a lot of different organizations out there that offer continuing education. And I would suggest that anybody that's going to be working with somebody would familiarize themselves through continuing education.
So pretty much like any other area of the field.
Exactly. And then ASHA has its own special interest group, 13, SIG 13 represent. So SIG 13, SIG stands for Special Interest Group, and a lot of their continuing education and messaging boards and connections that you can make specifically are around feeding and swallowing. Though I will say it does not specialize specifically in pediatrics. It's pediatrics, infants, adults, children, all matters of feeding and swallowing.
So once you get that assessment from a student or from a clinician or from an outpatient clinic for one of your students, and it has all these recommendations and you're quietly panicking inside, like I would be, what do? What's next?
So the first thing that I would do is to read the assessment and make sure that you really understand it. And then when you're reading it, to take into this one particular framework that I really like. It's from the International Classification of Functioning Disability and Health, but we're going to call them ICF. So that's an organization developed from the World Health Organization. And so it looks at the disabilities, but really focusing on the individual and the importance of participation in everyday life, because that's really what the functional outcome should be.
And just as a reminder to our listeners, we use a lot of acronyms here. And in case you're driving in your car or somewhere, don't worry, you don't have to write it down. All of these things will be listed as hyperlinks on our website.
So this ICF framework is really looking person-centered, which is really, really important. So we're not looking just at the disability, we're looking at the person and how we can impact their daily life. So if you're a school-based therapist, how is their either feeding difficulties or dysphagia, how is that affecting their ability to participate in school? So they sort of break it up into 3 areas. So body functions and structures. So as I'm reading this assessment, is there a medical diagnosis with physical limits to it? Do I need to pull in PT or OT? Because if this particular person that I'm assessing is in a wheelchair, I might need to talk to a motor therapist to make sure I'm positioning them appropriately. It also talks about making sure that we take a look at their assessments. Do we have access to all of the assessments that have been completed? If some treatment occurred before they came to you, can you get those notes so you can see what's working, what's not working, and what were the findings of that particular assessment? Did you talk to the SLP, the speech therapist, or not? And then point 2 is the activities. So when we're thinking about a school-based therapist, is this student able to participate in school? Or is lacking the hydration or nutrition, is that impacting their performance at school? So we're thinking about absences, tardiness, fatigue. That could even be tardiness between classes. Is that child not able to transition between tasks? Are they taking too long? Are they missing academic work? Are they able to participate in mealtime activities, but then also thinking about snacks or social interactions around food? And then the third point that they have us look at is the environmental and personal factors. So is the student aware that this is an issue, or are they unaware? Because that can happen, especially with our younger kids. Is the family aware of what the issues are? Do they find the feeding and swallowing to be difficult? Is the teacher or teacher's assistant that's working with them aware and trained? And for children with complex feeding and swallowing issues, the interdisciplinary team is really, really, really important.
The interdisciplinary team, I do want to talk about that, but I also wanted to take a second to go back to this concept of performance with absences, tardiness, and fatigue. Particularly for our younger clients or students, I feel like that can be attributed to so many different things. And so often it's overlooked that it could be related to nutrition. And I think that that's such an important point. I mean, it's so easy to brush off, oh, they're being they're having a tantrum, or they just don't want to go outside to gym, or they're just being a brat. You wouldn't say that in school, but I say that in my home, and you don't say, and it's not until you think, oh, well, they're starving, or they're dehydrated, or they're having some sort of nutrition related issue. I just wanted to point out that I think that's such a good point. So in terms,
I agree. It really is a big issue. And for some of these kids, teachers and other people on their team don't realize how big of an issue it is until that issue starts to get resolved through therapy. And then they're realizing, wow, maybe it wasn't that they really hated that particular activity. Maybe it was that they were hungry and they had a headache, because there can be other physical symptoms outside of just feeling hungry.
I am not a nice person when I'm hungry. I am tired. I can't focus. I am grouchy. I'm stupid. Like I can't articulate my thoughts. It's terrible. And I'm a full grown, healthy human being.
Hangry is a word for a reason. There's a reason that's a thing.
And when you're a tiny little person, you're doing 1,000 things at once and you can't regulate your own, senses to begin with. I feel like that's a recipe for disaster.
Or if you don't have the language to talk about those internal states also. I mean, I think for us, we can recognize perhaps and use language around how we're feeling. I have a headache because I'm hungry, but that might be terminology that the client doesn't yet have.
Totally. So
that's a really, really good point.
Back to what you were saying about the interdisciplinary stuff, though, because I think that's interesting.
So children that have complex feeding issues, so that might be related to other underlying medical diagnoses, perhaps cerebral palsy. An interdisciplinary team is needed to make sure that all the different factors that go into feeding and swallowing are being addressed, and that all members of the team are talking to each other and are on the same page.
So this is not something that a speech pathologist will always be doing on her own or his own.
Not necessarily, and especially in a school setting, I would say no. It's very rare that you would have a child that has a feeding and swallowing issue in isolation and does not have any other issues present.
Interesting.
The other team member that I often would recommend pulling in is going to be the ABA provider. A lot of times they're able to put together, and this is I don't remember what the term is, Kate, so you can help remind me here.
Oh God, don't put me on the spot. You know I'm not able to remember it.
But I find that ABA providers do a really good job of listing things out in steps and providing a really, really good list. List is the best.
I know that one. It's a task analysis.
So they do a really good job of pulling together a task analysis, and that's going to be really important for the children you're treating who have sensory based issues or who have a lot of behaviors around feeding, an ABA provider will be a very good friend of yours.
Well, the other thought I was having while we were talking about this fatigue and tardiness and, tantrums related to nutritional issues is that would be a great thing to take data on. If you have, all of these different potential variables that are contributing factors to fatigue or tardiness, when did they have their last snack? How many calories did they have? How much time lapsed between when they ate and when they had a tantrum? I feel like those are all, putting measurement to all of those things can be such a great way. And of course, you're, so biased, your BCBA can help you with all of that.
Mm-hmm.
And then one thing I think that's different in the schools than it is in some of the other settings is when we're thinking about nutrition, who's keeping track of that? Who's keeping track of how many calories are going in, and how much they're able to drink? How much do they need to drink a day? Are they maintaining their weight? Are they losing weight? Or is there a certain weight that they need to get to? And what's our goal for caloric intake? So a lot of times myself, I'm talking to the primary care physician, the pediatrician, or perhaps a nutritionist. So in the schools, I'm not exactly sure how often you'll be able to talk to a doctor, but I think it is a person that would be helpful to get their input if there is caloric needs that are going to need to be met during the day. So after I sort of have that framework in mind when I'm designing therapy, looking at body functions, what they need to be participating in, and then those personal factors, then I'm going to start thinking about what is my focus of treatment. So for a school-based speech therapist, they'll be reading this evaluation provided to them by an outside SLP. So when it's myself, when I'm providing an assessment and I know that the particular student is going to be treated in a school, I'm trying to provide as much information as I can about what types of strategies, modifications, positioning, limitations, those types of things in the assessment so that whoever is getting that assessment can read it and knows exactly what to do. Not all speech therapists are able to do that, but luckily you can pick up the phone if consent is received from the parent or email, and they'll be able to provide more information to help whoever's treating them understand the report more fully and to feel comfortable.
Well, and I think this is a piece too where whenever you have a student on your caseload who has multiple providers, I think there's only positive to be gained by having communication. Of course, you need to have a release of information signed, usually on both ends. But once that's in place, it's very helpful to be able to talk to people who, are like you, Tracy, and just have done a deep focus in this area, and then be able to collaborate with those people and figure out how to incorporate your recommendations into this different environment.
I agree. And I know sometimes it can be time consuming. And I know that school-based speech therapists often have a pretty big caseload, but I will say that it will save you time in the long run if you are able to contact that person. They'll be able to give you exactly what you need, or if you need more information on a particular topic, they'll be able to point you in the correct direction as to where you need to go to get more information on that.
Yep.
So when we're treating either feeding or swallowing, there's sort of different areas that we want to look at. So what's going to be the focus of our treatment? So that's sort of the next place I'm thinking about going.
And just as a quick recap for people who maybe didn't hear the first feeding podcast that you gave, the difference between feeding and swallowing, there's a distinction between feeding and swallowing.
Yes. So swallowing is the act of orally manipulating food and liquid and moving it down the esophagus towards the stomach. So that's swallowing in the most classic sense. And then feeding would be the process of getting it to the mouth. And so that might be, scooping the food, touching the food, smelling the food kind of goes into that as well. So the other sensory experiences around the mealtime.
And so there's the feeding piece outside the mouth, the swallowing piece inside the mouth, kind of broadly.
Yeah.
And you may have somebody who has needs in one of those areas or in both of those areas together.
Correct.
Okay. Thank you. Okay.
No, of course. So when we're reading the report from the speech therapist, they'll have talked about all of that information, whether it's just feeding, it's just swallowing, or it's both. In my experience, I found that a lot of children, because I work primarily with children at this point, will have both. So perhaps they have some sort of dysphagia, so a swallowing disorder that led to a lot of really negative sensory experiences. I don't know if you've ever choked, but it's pretty awful.
Bad feeling.
And if you're a child and you're swallowing and you're choking, you learn that when I put food in my mouth to swallow it, that makes me feel bad. And I don't have that feeling if I don't do that. So I've seen quite a few children where parents feel like it's strictly sensory, and then I'm starting to work with them and I say, actually it's both. I don't know, which one started first, but that's why it's really important to get that case history to say, they had a lot of difficulty latching with breastfeeding, difficulty moving to a bottle, moving off the bottle to solids. So just to sort of reference back to the assessment, that's part of what I'm looking for.
Sure.
So as I'm treating either feeding or swallowing, my goal might be that I want to restore normal function of swallowing. So if there's a dysphagia, to try and repair that, so a rehabilitative focus. Or it might be a modification either to the diet or the behavior. So that's going to be more of the compensation piece, or it might be both. And oftentimes it is both.
And as the school person, you're going to give me this information, right? I'm going to get your report and it's going to help me understand as the reader, okay, it's feeding, or it's feeding and it's swallowing. And these are some of the strategies that we might try. Or is that a phone call?
It probably would be both.
Okay.
When I'm doing an assessment, especially if it's one that's being covered by insurance, I need to be assessing for something. So at the end of my assessment, I need to provide a diagnosis. So that might be a feeding issue, or it might be swallowing. If it's swallowing, I need to describe. You just don't say he can't swallow or she can't swallow. You need to say they have difficulty with the oral phase, so the chewing or the forming of bolus, or maybe it's the pharyngeal phase, so that's the part where you're moving the bolus down through your throat, or maybe it's both. And then I need to say, okay, what's the severity? Are they having a little bit of trouble or a lot of trouble? So that all should be in the evaluation. And if it's something where you feel like it's maybe not super specific, or if the particular student wasn't really able to participate in the assessment, which can happen, the speech therapist would be able to talk to you more about what they would have liked to have seen or what they expected to see on that evaluation. We're either looking to rehabilitate, so that's somewhat more with the dysphagia and somewhat with the sensory too, I guess, or we're looking to compensate for what is either missing or what was lost. So when I'm talking about loss, that might be a child who's had a stroke or some sort of a traumatic injury that might have caused their difficulty with swallowing. So compensation techniques alter the swallow. So that's going to be more of the diet modification. So when I say diet modification, I'm meaning more about changing the thickness of the liquid, or maybe changing the solid. So that might be chopping the food or putting it in the blender. So what people are thinking more of the traditional thickened liquids, blenderized food, compensation strategies would be defined in that report. And for some children, especially children with dysphagia, that's something that would need to probably be part of the therapy. So if they go to swallow a piece of steak, and their body can't handle it, either because they can't chew it or because it's getting stuck in their throat, then they need to have softer food.
And those would be things too that you're also just thinking back to the ICF criteria and using that as a framework. Mm-hmm. You're thinking about giving them access to all of those different things, right? You want them to access nutrition, you want them to access these different activities. And so part of how they might do that is through this modification.
Exactly. Yep. And then with some of the children that have more of the sensory-based issues, it might be that they cannot handle food that is really bumpy or food that has a really strong flavor. And so they need to have the modification in that way, where maybe it's a little bit more bland or a little bit more of the same foods. So that's sort of the modification that they're doing, and therapy would work on helping to introduce other foods for that.
So being in a school environment, having worked in school environments, I think about the IEP, and that sounds like sort of the accommodation, like other types of accommodations we might make in order to enable somebody to access components of the curriculum, right? So this is just an accommodation. So some change that with this change, the person is better able to access these different activities, in this case, snack, lunch, nutrition.
Exactly. And this particular part of what I'm talking about has a lot more to do with dysphagia. So that's going to be more of the swallowing issues. And I'll go into a little bit more on the feeding later on.
Okay.
So the other piece that I wanted to talk about as far as when we're looking to restore function is going to be possibly looking at some kind of exercise. So I think that this is, in speech therapy, a really big hot button issue, talking about oral motor exercises.
But I thought you'd never bring them up.
But specifically for people who have a deficit motorically, it can be a really important tool. So I want to be perfectly clear that I am not suggesting oral motor exercises like non-speech oral motor exercises specifically for speech and articulation. That's not what I'm saying. I'm saying that for children who have difficulty closing their mouth because of a motor issue, that types of exercises that we can do will help them to get the strength, coordination, and range of motion required to participate in this very functional task.
So non-speech oral motor exercises are they evidence-based for feeding and swallowing issues?
They are not evidence-based. And the fact that they are not evidence-based has a lot of evidence. I hope that's not too confusing.
No, that made sense. But that we have bodies of literature about them not being evidence-based for speech improvement.
Yes.
But what about for feeding and swallowing?
There is evidence around that.
Okay, so they are evidence-based for feeding and swallowing issues.
For feeding and swallowing issues, yes.
So you get a green light. If you're doing non-speech oral motor exercises for feeding and swallowing, the speech police are not going to come and get you.
Yes. If you are suggesting to blow bubbles so that they can say a B sound, the speech police they're not going to like that.
You're under arrest.
Right.
But
right.
if your ability to swallow is impacted because you don't have the strength, for example, in your pharyngeal muscles, and you want to improve the strength to move the bolus down your throat into your stomach, then the exercises are going to be helpful. Those aren't necessarily oral motor per se. Those are pharyngeal, but there are exercises like lingual exercises or working on jaw stability or jaw strength. If you have a very weak jaw and you are unable to chew, then you are not going to be able to chew your food. And there are certain exercises that can be done that are often done to help with that. But the exercises would be specifically if there's some sort of weakness. So if somebody doesn't have weakness, I'm not going to be suggesting to do exercises. It really is specifically targeted, and it needs to be targeting a weakness.
Okay, good. Glad we covered that and cleared it up.
Yeah, and there is quite a bit of research out there, and if people are interested, I'll make sure to send that so you can have that link. But there is just as much research that's saying that we don't blow bubbles to help with swallowing.
So bubbles, just for the fun of it.
Bubbles
Just
are
for fun.
They're for fun, and maybe for communicating
Language.
or as a
Motivation.
reward. Yeah, motivation. Yeah,
Reinforcement.
there's the ABA piece, right?
I can't help it.
No, but it's good, and it's something that I have implemented
It's
because
just part of me, Tracy. Don't judge.
well, feeding and swallowing, it's something that is invasive and that is really hard for some children. So bringing in a little bit of whimsy can be really helpful. It can build rapport. It can help to break the ice.
I love the word whimsy. That was such a good description.
So we've gone through sort of what my framework is, trying to figure out what the focus is. Is it compensation strategies or rehabilitative? And then when I'm talking about treatment, I thought that I'd touch on a few things that are really important for treatment regardless of what the diagnosis is. And the first thing that I always make sure to be aware of, allergies. So if a child has a peanut allergy, I need to make sure that I'm not feeding that child food that has peanuts in it. Or if they have diabetes, I need to make sure that I'm checking in with the nurse. So if there are any medical issues along those lines, that's the first thing that I check. And then the second thing that I'm looking at is posture and positioning. So is this child able to sit in a seat physically? When they're eating, are they the kid that's sprinting around the room and trying to chew? What are they doing while they're eating? And is that safe for them? And is it effective? If they are running and screaming in the lunchroom, then that's not safe, nor is it effective. So that's one of the things that I'm definitely checking.
So I'm assuming this is a piece of your treatment where you would consider bringing in the PT and the OT.
Yeah.
If you're a school-based speech pathologist and you are feeling like, there's a lot of movement, posturing, mobility issues here that are outside of my comfort zone, and your OT and PT says, well, that's not really I don't really have any experience with feeding. Are there resources? Is there definitely something that they can contribute? Is that a relationship or a professional relationship? Are there ways to sort of bridge that gap? I'm just thinking about all of the school-based SLPs who, you have the team that you have, you don't have the OT and PT feeding specialist, wheelchair specialist down the hall.
So I will say this, that if a child is in a wheelchair, they are going to have a mobility specialist. So whether that's at the school or not, I think it depends on the type of school. If a child is in a wheelchair and needs quite a bit of physical support, then my guess is that they're in a type of program that would have a physical therapist, or if they didn't have one on site, that they would have access to one.
Well, and I would think it's also very similar to speech language pathologists, where it's certainly within their scope of practice. It might not feel like it's within their scope of competence. So similar to us, that would be an opportunity for professional development in that area and ongoing growth. And I think that multidisciplinary, part of what I have loved about working in the schools is that you have the opportunity to work with so many different people and utilize a team-based approach. So even if you're not quite sure that you need the support of an OT or a PT, if those providers are on a student's caseload, it's probably worth including them when you make the call to their outside provider, because more input tends to be better.
More brains are always better than one brain.
Mm-hmm.
Is this an area where we have overlap? So I know at least for AAC, there are some, access things related to selecting icons or positioning of switches that I feel comfortable doing that are related to positioning. Is the same true for feeding, where a speech pathologist can do some things related to positioning, or is that something that's only owned by the OT?
I think yes. So I will say that there are certain things that I feel really comfortable with. So if it's my first treatment session and the occupational therapist is not available for me to speak to, I'm not going to tell that person, well, they're not here, so I can't support this. I'm going to use what I know, see what works, and then I'll probably go and check in with the occupational therapist, say, this is what I did, this is what worked, and this is what didn't work. Can you provide me some feedback on that? And also thinking back to that evaluation, I know that I sort of sound like a broken record here, but it really is important. Somebody has already had to figure this out and they've documented everything. So if in that report they're saying that there's a lot of positional issues and they feel that the positional issues really affected their ability to eat and swallow, then I'm contacting the PT or the OT before I'm even going to see this kid to make sure that I have what I need, or at least some tips and tools to kind of troubleshoot once I'm going in there for my treatment.
That makes sense.
So position is for eating is really important. If the child is not sitting, if they're not focused, then they're not going to be safe for swallowing. If you think about, kids running around chewing on food, they're often falling, they might choke.
Do you know what I saw today? I went out into my backyard and we have a trampoline and my son was jumping on the trampoline eating a rice cake and I almost murdered him because it was so unsafe. You're right. And I told him not to and he did it anyway. But you're right. I mean, kids by nature sometimes they're on the move.
And I think that that's a really good point, is that we are taking into account what their developmental level is. So, at some ages, if you will, that sort of walking around and grazing is normal. But if walking around while chewing might make them choke or might make them aspirate, where food is going to go into their lungs and that might cause pneumonia, then we really need to factor that in and try and keep them safe. So not allow that.
Yeah, I do not recommend that. Make sure your children are not jumping on a trampoline and eating.
So whenever possible, we want the child to be sitting upright. So thinking 90 degrees. So their ankles should be at 90 degrees and their feet should be supported. Their knees should be at 90 degrees whenever possible. I know that there are certain disabilities or diagnoses that will prevent that from happening, but as best as we can support the legs. And then the hips should also be at 90 degrees. So 90, 90, 90, thinking like that. And that's going to be the best position to make sure that they feel supported. And that's also important for our sensory kids so that they can be getting the feedback from the area that they're sitting in. And then, so positioning is allergies, thinking about that, and then looking at that report, any diet modifications that need to happen. So this is an area we didn't get to talk about a lot in the previous segment, was all of the different language around thickened liquids or diet consistencies. So when I say diet, I don't mean, intermittent fasting.
Eat more vegetables.
Or, 5 a day.
Yeah.
I'm meaning specifically the types of food that you're eating. So there used to be sort of like a lot of language around it, and it really varied from location to location. So thin liquids for one person might be nectar thin for someone else, and a blenderized ground for one person would mean something different for someone else. So people were going either between hospitals or outpatient facilities, and somebody would read this and it would mean two different things. So sometimes it would mean these people or children were ending up on a more restrictive diet, which is quite unfair for them, because if you've ever had to eat, if we're calling back pureed eggs, it's quite unpleasant if you are able
thanks.
if you are able to eat, hard-boiled eggs.
Nope.
Or what was happening is people were being given a less restrictive diet. So they really did need the liquids to be thicker, but they weren't being thickened. So this new framework came out, and it talks about the different, what the different levels are. So I don't know if that's something that you guys would be interested in talking about.
So I think it would be interesting because I have done most of my work with dysphagia way back when I was in grad school and I was in a subacute rehab setting. And what was helpful there was that basically everything came out of the cafeteria. So whatever came out of if the cafeteria said it was mechanical ground, then that's what it was. And, you would open up the little thicket packet and thicken up the liquids. And I think as somebody in a school, if I get a recommendation, maybe I don't know what that looks like. Is there a place where I can go find out about it?
So the framework that is being implemented more is this international dysphagia diet, or dysphagia diet, depending on where you went to grad school. And they have their own website. It's really easy to find that will talk about what the different levels are. So it's sort of this like 8-point scale ranging from 0 to 7 that more and more people are starting to implement. You might see some of that older language, but thinking about 0 being thin liquid and moving up to 7, which would be the regular diet. So, hamburgers with lettuce, cut steak, really hard potato chips, things like that is going to be up at that level 7. So when people are needing a diet modification, they can check on that website if they're unsure. And I will say that when thinking about a school, just because a parent is sending a food in with a child does not necessarily mean that what is being sent is appropriate. So it's not something where you can just sort of go with it. It's important to understand what the levels are and what's safe.
Well, and I think safety is such a big concern, especially if you're not incredibly comfortable with feeding and swallowing. That's usually why you're not comfortable. You're concerned about the safety of the student. And so having a standardization like that, I think makes a lot of sense. We can have that link to this resource up on the website so people can check it out. I know I'm going to check it out after talking with you. I'm very curious to learn more about that.
And then they also have a lot of pictures and a lot of examples so that it's easy to check. And then when we're talking about liquids, I just want to remind everybody that it's what the consistency is at room temperature. So Jell-O is not a solid. Jell-O is considered to be a thin liquid. Ice cream is a thin liquid. When you put these foods in your mouth, they're not going to hold their shape and hold their form. They're going to become a thin liquid. And so that's why those two particular foods, we need to consider those thin liquids, though it's an argument that I've had many a time.
Okay, so I feel like we've learned so much about modifications. We've learned a lot about different textures. I have learned a lot because I don't know anything as we've reviewed a bajillion times. Maybe we should move on to our second learning objective, identifying and explaining exposure strategies to address sensory-based feeding issues. And we've talked about this a little bit already, especially as it relates to, have we talked about this already, or was that before?
I think that probably was in the other podcast that we touched a little bit on that, and maybe a little bit in this podcast earlier. But sensory-based feeding issues are pretty common. We're seeing it a lot more often than we used to. It could just be that people are more aware of it and looking for it. But when we're thinking about the sensory-based feeding issues, we're looking at kids who are avoiding just whole groups of food or textures of food. They're super intolerant to the sensory input. So that might be sight, like looking at it just upsets them. The smell of it could make them physically ill. Touching the particular texture makes them feel upset, or maybe it's the taste. And these are the kids that are going to eat the same regardless if they're at home, if they're at school, or if they're with their friends. They're going to be eating the same regardless of what location that they're in.
I think that that's such a good point, and I'm sure we're going to get to this, but just the difference between a sensory-based kid and a behaviorally based kid. A behaviorally based kid would, well, when so-and-so feeds them they have X behavior, but when they eat in this other environment, the environment will really determine that. So I think that's such a good description of what to look for in a sensory-based feeding issues, right?
Yes. And I will say that a lot of children that have sensory-based feeding issues, or adults, will also have some behaviors around it. And Kate, you probably could talk more about it, but those behaviors might be specifically to avoid the sensory experience, which is quite unpleasant to them or painful. So with these kids, we're going to want to look at that evaluation and check to see what their comfort level is. What are they doing, or what are they not doing? What are they interacting with or not interacting with? And you always want to start at the most comfortable place. So if they're super comfortable with purees and they're just not doing well with crunchy, you don't just hand them a veggie straw. You start at where they're comfortable, and then you go from there. And with children with sensory needs or adults, building rapport is really, really important, because it builds trust. And it's a really invasive thing for them to have somebody put something in their mouth. These kids might be gagging on it. And if they don't trust you, they're not going to let you pass their lips. They just won't.
That's
so you
a
always
huge
want to,
thing. And I
yeah.
think, just to reframe that again into behavioral terms, you have to make yourself reinforcing, right? So the person, has this association, the client, the student has an association with you that this person is not going to give me a bad experience. This person is not going to, your presence is a positive thing and not a negative thing. I think that's so super important.
And I will say that that's important initially, but at some point you are going to need to move past it. So you might need to make them feel uncomfortable. You might need to make them face that really unpleasant sensory experience. They're going to be a lot more willing to do that if they trust you and if they have all of these positive experiences with you leading up to that. I'm not going to start treatment just by jamming something in a kid's face, because that's their first memory of me. And if their first memory of me is really unpleasant, then they're not going to want to work with me. So as I'm thinking about these kids reading that report, maybe talking to the ABA or teacher, what's reinforcing for them? What do they like outside of food? Do they really, really like My Little Ponies? Can we get a My Little Pony plate? Or can we get a My Little Pony placemat? Something like that to just reinforce, or stickers perhaps.
And I think for a lot of these kids, I'm just making the assumption that this is a potentially it's very sensitive. It could be a really negative experience. And I think from a behavioral standpoint, you want to bring out the big guns, right? And you want to make sure you're choosing something that is an actual reinforcer and not just something that they like. And I think that's something that you can really, an instance, and I know you talked about collaboration before and team assessment and team treatment, but this is really a place where you can utilize your BCBA to make sure, okay, well, they like little ponies, but they got like 1,000 little ponies back in the classroom. And here we are doing this really horrible thing. My Little Ponies is not going to cut it. We need to get creative. We need to maybe do a reinforcer assessment and actually put some science behind what is going to increase the likelihood of them engaging in some more pro-feeding behaviors.
Absolutely.
I made up those words, pro-feeding behaviors. I'm not sure if that's real. Just caveat.
I like it. I think it sounds fancy. When we think about these kids, these sensory kids, so we know these are folks who are avoiding certain foods or texture groups. They don't like certain sensory input. Are there any other things that you're sort of looking for with this group of students that kind of puts your mind in that direction?
Yes, I will say that a lot of times these are the kids that are the chipmunks. So they, really want to please you. And so they're going to put the food and they're going to try and hide it in their mouth, and they're going to store it in their cheeks, and their cheeks are going to be puffy, and then they're not going to swallow it. That's one of the things that I'm looking for.
What do they do with it? Where do they think it's going to go? They just like hold a whole bunch of food in there?
So I will say that it's not something that they're thinking about. It's just happening. So if it's really unpleasant to swallow, if it's painful for them, then they're going to do whatever they can
avoidance behavior
to avoid that really negative experience. So they might just be holding the food in their cheeks, and some are really good at hiding it. You might not notice it. So looking back to that evaluation report, if this is something they're doing, you're going to need to be checking in. It could also be the kids that have low sensory, so hyposensory. So they might be the kids that are filling their mouth with food, going really, really fast, or the kids that can't feel the food in their mouth. So then they're just having trouble figuring out where it is. So sensory is encompassing quite a bit. So it's not necessarily just something we're looking at if it's an avoidance thing. It might be something where they're not sensing the food where it is in their mouth. They might be drooling a lot because they just can't feel it. So these are all the things that we're looking at. So when we are thinking about what we're going to be doing with these kids, we want to make sure that we're bringing in all of the different senses.
And you also, just back to some of that swallowing piece, you need to be able to take that food and put it together and form a bolus so that it can go to where it's supposed to go. We don't want residual food hanging out in the cheeks and in between the gum line and the cheeks and underneath the tongue, because that's also not helpful.
So for some of these kids, it might be to make sure that they're not going to have that food go down and choke on it later. You might need to be looking in their mouth afterwards. So those are going to be the kids that are not going to be able to eat independently. These are the kids that are going to need to have somebody with them checking. And a lot of times they'll have a favorite place that they store food. And so you sort of look in their favorite place. It's maybe it's between the front teeth and the top lip, or maybe it's further back or under their tongue. You should always check everywhere, but usually they'll have a favorite place that they sort of put things. And it's important to look at that. Yeah. So when I'm figuring out what to do with these kids, sort of that slowly desensitizing, I'm thinking about texture, flavor, temperature, scent, and with a lot of kids, it's even proximity. Will they allow the food to be in the room? Will they allow the food to be on the table, on the plate? At what point are they having that reaction? Is it when it's in their mouth? If so, then I'm going to think about, okay, well, how about bringing it to their lips, around their mouth? Are they allowing that? And working slowly to make sure that they're feeling safe and comfortable with it. If it's a kid that's not even allowing the food on their plate, maybe my first goal is to take a look at, okay, you need to just be able to have broccoli on your plate. And we need to wait until you're okay with that before we start working on chewing some of these vegetables. Because if you're not allowing the food in your room, the room that you're in, you're not going to allow it in your mouth.
And so it's really tolerance.
Big jump.
Yeah.
And sort of shaping their tolerance to the different presentations, successive approximations towards actually chewing and swallowing the food.
Yes, exactly. And some of the kids, it might be that you start with something, if it's a tactile thing, you might start with mashed potatoes. Maybe it's a really smooth texture that they do well with. And then the next time when they're really successful with that, you're going to do some lumpy potatoes. So maybe it's not perfectly smooth. Maybe there's some chunks, and working your way towards French fries.
So as you're designing all of these treatment techniques, and I'm hearing you talk about smooth potatoes versus slightly varied textured potatoes, you're in a school, are you really relying on the parent to send in that food? Because I feel like this requires a lot of coordination between you and home, because I know that the cafeteria isn't going to make you different, and I'm just thinking this comes into so many different issues related to kids who have food insecurity in the schools, or how are all of those things, that seems like a very complicated thing to navigate.
And I will say that is something that's an issue that a lot of speech therapists, even outside of the schools, are working with, unless you have a food source like in a hospital. So if your goal is to work on crunchy and crunchy didn't come in that day, you need to get creative. So it might be other sensory experiences to try and approximate that. So if they're having a really difficult time having something sticky on their hands, maybe you're playing with gack. If they're having trouble with having broccoli on their plate, maybe you're reading a book that has to do with broccoli, and then you're bringing the broccoli in another way. You're drawing a picture of broccoli, or you're singing a song about broccoli. So there might be other ways that you can target or approximate it.
Got it. No, that makes sense.
So what about food chaining? Like, when do you figure out what is food chaining, and when do you figure out if that's a strategy that also could be helpful? I know we're working, you're working on the sensory piece, you're working on all these other components. What about, you're doing the smooth potatoes?
Yeah, so food
This is learning objective number 3, by the way.
Yes,
We're moving right along.
So food chaining, it's a treatment approach that introduces new foods, but it takes a look at the foods that the child has been successful with in the past, or successful sensory experiences. So the foods that they are going to be presented with are going to be similar in some way. So maybe it's the same color. They eat tomatoes and you want them to eat a red apple. So that would be sort of food chaining by color. If it is similar in texture, they eat smooth pureed potatoes and you're wanting to get them more vegetables. So you could maybe do smooth pureed butternut squash. It could be similar in texture. If they really, really like salty chips, maybe you could food chain in flavor and texture by moving to like a saltine or a Cheez-It, something along those lines. But you're taking something that the child already likes, they already have positive experiences with, and you're trying to build on it like that. And the main goal of food chaining is enjoyment. So it's to make food and eating pleasurable.
Which I would think is kind of a huge goal over. I mean, we have the goals of nutrition, we have the goals of participation, but if you're able to help somebody who's had such negative experiences around eating find it to be something pleasurable, that's very powerful.
I agree. And I will say that this is a technique that's worked really well with a lot of different diagnoses, but I found a lot of success with children or adolescents who have autism. This is a technique that's worked really well. What's important is that you're not targeting 15 different foods at once. You pick one food and you go with it. It's a strategy that can take a while. It's not one that is moving very quickly. But the children that are having these really severe sensory based feeding issues where they're not eating many foods or they're eating only a couple of foods, it can be a really powerful technique, a really powerful tool to have, because you're able to get a plan. So you have your food that they're working with, you have your goal food, and it gives you a map between point A and point B. So maybe there's 1 step or 2 steps or 3 steps to get there, but you have a plan.
So
go ahead, Amy.
If you feel like you feel like your student, they like mashed potatoes, they like mashed squash, they'll eat mashed carrots. We want to try another mashed food. I don't know, mashed turnip. That's a strong one, but
that's disgusting.
Mashed turnip. I'm a fan. I don't know.
I might eat that actually.
Mashed turnips? What are you, in the 1800s?
Sort of.
In Ireland? Come
on. So let's say mashed turnip. Like, how long do you stick with that? Maybe it's like for me, it's like a family dish. We eat it at Thanksgiving. And so like, how long do you stick with a food that you've selected before you decide like, oh, this doesn't seem to be going anywhere?
So I will say that I usually will pick 2 foods,
Okay.
especially if it's a child I'm working with who is in a daycare or a school setting, because if I put all of my apples in the mashed turnip basket and mashed turnips are not a choice that particular day, then what am I going to do? So it's nice to have a couple of different goal areas. That way you can pick and choose. And some days the child might just not be able to work with it. And what's really powerful is giving them a choice. And so, okay, do you want to work with purees today, or are we going to work with crunchy?
So I think that's really helpful information. And I guess another question that comes up for me is if I decide, okay, I've spoken with the students, outside evaluator, we feel like, we're going to pick crunchy and squishy, let's say these two foods that we're working on. Am I also still working on other components that we've talked about? Like, am I also still working on making sure that we're still eating all the foods that are in that kiddo's repertoire? Or, maybe moving toward just thinking about that IFC classification system that you're using, ICF. And thinking about, am I looking in other areas, maybe during snack, maybe snack is a time that I'm not working on this food chain, and snack is a time that I'm working on foods that the student already eats successfully and working on moving toward more of that social interaction? Or no, is that too many things happening?
I think it goes back to what your level of comfort is, because I'm often working on all of those things at once. But if it's a food that they like, I probably would focus more on the dysphagia piece, because I'm going to be able to get more repetitions. And if it's a food that they don't like, I'm trying to get, as many introductions to that as I can across therapy.
I feel like this is an incredible amount of information, and I have so many more questions. I had like 1,000 thoughts while you were talking, and I have to keep them in my thinking bubble just because of the time. But I'm wondering if you would be willing to come back. Is 3 times a charm? Would you come back again, and can we talk more about this sensory based stuff and food chaining? Because I'm literally, my mind is like firing.
Of course.
Smart thoughts, I think, not stupid.
Of course. I really am very, very passionate about working with feeding and swallowing. It's an important thing for people to be able to do. And I think that if more speech therapists were able to feel comfortable and confident working on this, we could make a really big difference in a lot of people's lives.
I wonder if our listeners, anybody who's listening, if you send an email to info.
Our email is info@slpnerdcast.com.
Correct. Send an email to that, info@slpnerdcast.com. But let us know if there are specific questions you'd like us to ask Tracy, because I think that I feel like, Kate, the more I talk to Tracy about this, the more questions I have.
I was having the exact same thought. And then I was getting mad at Father Time, who was taking time away from me because I had so many more questions. But we really appreciate you coming and giving us all of your knowledge and putting so much thought and effort into this. Tracy, you're the best.
Yes.
Well, thank you so much for having me. And I can make sure to send along resources and different speech therapists or different courses that I've come in contact with that were super helpful. So if people are looking for more information, they can go right to the link.
Awesome.
Well, I think that pretty much wraps us up. This was another really fun episode. So we will see everyone here again soon. Tune back in for more fun topics to come on AAC evaluation strategies and all kinds of good stuff. So leave us an email, check us out on our website. You can find us on Instagram. If you're so inclined, leave us a review. Tell us what you liked, what you didn't like, request an episode or a topic, and we will hopefully hear from everyone soon.